Hi, good morning, everyone. Welcome to 89th session of CMAAO International Weekly Meeting. We started this session about almost a year ago, and the whole idea of these sessions were to bring all the medical associations. We have about 19 medical associations, and we have support from US and Europe to come with the expertise of what's going on in the country. And COVID was one of the reasons why we started all these meetings. And now today we have another variant which is coming in, and we have support coming from South Africa on a very early stage. Today we have a very important topic: post-COVID tinnitus, hearing loss, and vertigo. This is for a long COVID. And to present this, we have Dr. J.M. Hans. He's a Padma Shri awardee. He was very closely working with Dr. K.K. Agarwal and his colleague. He's a topper and gold medalist from PGI Chandigarh. He has done a lot of work on cochlear implant surgeries and has done over 3,000 surgeries. He is also the founder member of Cochlear Implant Group in India. He is also the chairman of Dr. Hans of ENT and Cochlear Implant. He was the honorary advisor and a consultant to former Prime Minister of India. Over to you, sir.
Thank you, Saurabh, and I'm indeed delighted to be part of this August meeting today. As an ENT surgeon, we faced a lot of problems. First of all, the patient would cough at us. We would get the patient tested and he would come positive with COVID, and you can imagine what we went through. Many ENT surgeons lost their lives because they were in direct contact and mouth-to-mouth contact with the patients. And whatever precautions you take, there is always a possibility of the virus getting into you. And that's the reason why. But it is the post-COVID time which is even worsening. So I will start my So it is the post-COVID time now. As the time is passing by, we are realizing as ENT surgeons, and maybe because I deal more in the inner ear diseases now, cochlear implant being part of that, hearing loss, tinnitus, and vertigo, I have seen almost 10 to 15-fold increase in patients suffering. And not only that, the age variants are quite disturbing. We now get as young as 20 years, 18 years children getting these problems and coming to us, whether it is COVID or whether it is anything else. We are going to discuss now this today. And I must tell you, this is quite rampant. I was told that post-COVID, there'll be a lot of stress-induced diseases, psychiatric problems. But in ENT, we saw a lot of these cases. Now, going back to the history, any of these upper respiratory viruses which we had, whether it was rubella, whether it was mumps, measles, HIV, cytomegalovirus, herpes zoster, varicella zoster, any of these viruses, because they were in the mucosa in the upper respiratory tract, they had a predilection for the inner ear. They had a predilection for the inner ear. You would remember that measles, mumps, all these would lead to hearing loss, tinnitus, vertigo, and other things. And they would act at different parts of the inner ear, whether it is the stria vascularis, which is the blood circulation to the inner ear, the organ of Corti, which has the hair cells, or the nerves, the neural part of the dendrites, which starts from the basilar membrane and then go into the spiral ganglion and then form the auditory nerve. Now, these were the direct things which happened. The indirect, any virus, whether it was the earlier viruses or now this virus, leads to a lowered immunity inside the cochlea and as general in the host, leading to further complications which are happening. And that is what now I'm going to discuss here. And coronavirus, or what we call the Wuhan virus, was no different. It behaved the same way as most of the upper respiratory viruses which were there earlier and which were causing problems in the inner ear, hearing loss, tinnitus, and vertigo. And this is what I'll be discussing, that why it happens, why these things happen. Now, the most important structure in the inner ear is this endolymph, the green area, what you see. That is the cochlear part, the saccule, the utricle, and the semicircular canal. So this is the hearing part and the balancing part, as we call it. And it is here that something goes wrong, which I'll discuss shortly, and leading to either only cochlear symptoms or vestibular symptoms, or both. I mean, it may start inside the vestibule, leading to vertigo, dizziness, etc., to start with, or it may start in the cochlear part, leading to tinnitus, hearing loss, etc., and then later on getting into the whole cochlea and bilaterally. So this is what it is. Now, we all know that the endolymph is formed inside the cochlea in the stria vascularis, and then is absorbed also by the stria vascularis. Now, it acts not only as a secreting area, it also acts as a glomeruli of the kidneys. And that's the reason why we will all know that embryologically, both the kidney and the inner ear derive from the same germinal epithelium. And that's the reason the stria vascularis also acts as glomeruli, where the endolymph gets absorbed and a fresh one is then formed. But there is another way this endolymph gets absorbed, and that is by the endolymph going into the endolymphatic duct and then into the sac, and from where it gets absorbed. Now, the problem which we saw in the earlier viruses, we have not been able to diagnose where this coronavirus acts based primarily, but we know by the earlier viruses that it was acting at both these places, the stria vascularis and the endolymphatic duct system. So this is what we are going to discuss today, and you will have to keep this in mind, the inner structure of the cochlea and the embryology of the cochlea. That's pretty important. So whatever is happening inside the cochlea is why it happens. That is what I'm going to tell you today. Now, the most common conditions which I encountered in the last few years was endolymphatic hydrops. That means there is increase in the volume of the endolymph inside the inner ear, leading to a hydrops formation. And this is a prerequisite of Meniere's disease. Now, Meniere's disease, we call it Meniere's when it has the four triads of what it is, and I'll let you know shortly when I discuss about that. But endolymphatic hydrops means the volume inside the endolymph is increasing. Now, you can imagine that if you drink too much of water, your stomach starts aching, and then you have other problems. Similarly, when the endolymph in the inner ear starts increasing, and if it is in the cochlea, the first symptom would be of fullness, pain, a kind of a deep-seated burning sensation. These are the vague complaints which people come with, and then we have to keep it in our mind. And the unfortunate part is that not many of our physicians understand the disease at this level. We have to pick up the disease at this level so that we can treat it properly, because once it is established, that means the endolymphatic duct is now totally occluded. The treatment becomes impossible then. Then it is an irreversible situation which we create. But if we are able to diagnose at that stage, when the debris in the endolymphatic duct can be washed off, that is a stage when it is almost a reversible condition. So in the initial stages, whatever be the cause, whether it is the inflammation caused by the virus or the stress causing the problem, that I'll come shortly and let you know. Labyrinthitis was the other thing, whether it was viral or superadded bacterial. Once the resistance of that, the immunity of that area going down, and bacterial and fungal infections taking over, we had a lot of labyrinthitis coming. Vestibular migraine is another case. A lot of this was seen. And we all know that vestibular migraine can either be in the nuclei, the vestibular nuclei. Migraine has a lot of role to play, but it can be without that also. And the precipitating things in vestibular migraine was either the endolymphatic, so we call it the migraine Meniere's syndrome, or it can be otherwise also. When you're on the computer for too long, you're watching your phone for a very long period of time, you're stressed up, this condition occurs, and this was rampant. Earlier before COVID, if I used to see about 3-4 cases a day because I deal in this, now I see at least 10 cases a day of these, and to diagnose it properly and to treat it properly was really something very important. Now, the last but not the least was benign paroxysmal positional vertigo. And I'll just say a few words when I'm coming to why BPP was important. We all know benign paroxysmal positional vertigo by the involvement of the posterior semicircular canal, and we used to do epilays. Now things have changed. Now we know that it could be in any canal, it could be multi-canal, it could be bilateral, and that's why the maneuvering exercises what we do for treatment varies. There are about 15 kinds of BPPV, and there are 15 kinds of maneuvering exercises what we have today, and that is why it is very important to pinpoint where exactly BPPV is so that we can do. I will talk about, when I talk finally about the etiology and treatment of this, I'll talk only about endolymphatic hydrops and just touch the other cases because they are not so important. They are diagnosed by an expert only, but can be diagnosed even if you don't have the sophisticated instruments what we have in our clinic, and I'll let you know about that. Now, what happened? What happened in COVID-19? There were two things. It was the virus which caused the problem directly, and it was the associated stress. There was a lot of stress, and these two things had their own role to play as far as the inner ear diseases were concerned. Now, what did the virus do? It had a direct effect, direct damage on the intracochlear structures, whether it be the stria vascularis, the organ of Corti, or the dendrites, anything. It had a direct effect on that, and that's the reason why people had these problems, which I had already told you. And this virus would induce an inflammatory response, leading to a debris formation inside the inner ear, which would then go and get stuck at different places inside and block the drainage of the endolymphatic system, and thus cause hydrops. But it also caused immunosuppression. When I started talking on the TV for black fungus, as that was another thing which came in our field, and we had to talk a lot about that, I used to say that there is definitely some, maybe one of the, problems of coronavirus was the immunosuppression. And it was behaving like as if the AIDS virus did, and this immunosuppression led to the other problems, whether it was superadded bacterial or fungal or all these infections which were occurring. Now, what did stress do? Stress was the another thing which had a rampant effect on the inner ear, and this was because the plasma levels of the stress-related hormones such as the antidiuretics and catecholamines had increased. You would all realize that if the endolymphatic system has to clean up, there has to be some diuresis inside, and that effect was not there. The antidiuretic hormones had increased inside because of the stress, and that was leading to the accumulation of endoliph inside the inner ear and thus causing the problems. These are a cause of endolymphatic hydrops as they alter inner ear dynamics. So they were changing these two hormones. The quantity of this increase in this was changing the dynamics of the endolymphatic system and thus causing a hydrops formation. And secondly, the disease may worsen the emotional state, which in turn may worsen the symptoms perception. So even if people were not so bad, as far as the symptomatology was concerned, but just because the whole emotional state was broken, and they were in a bad emotional state, that what is happening, I hope I am not getting a grave disease, that the presentation was, we had to deal with their emotional state also. Now, yes, we all know that whenever a disease occurs, whether it is cancer, some people may keep smoking all their life and not get carcinoma of the larynx, whereas others may just get it without even smoking. And that is why we put the genetics in place, and we say that probably they are predisposed genetically to this kind of a disease. Genetics, autoimmune is a very, very important. And when it comes rampantly and bilaterally, we have to even test for autoimmune disease in the body and see for other autoimmune disorders like rheumatoid arthritis or scleritis or other things. Allergies, very important. And it was this during COVID that we started doing allergy tests in our clinic, and we saw that many of these people had underlying allergies, which we started treating by giving them immunotherapy, vaccines in the form of oral drops, and they improved considerably. So it was the underlying allergies which was causing, making these people prone to this kind of a situation after getting exposed to the virus. Ototoxic drugs. Now, it was seen that most people who were on aspirin, and most of us have, cardiology problems. We are on blood thinners, and aspirin is known to affect the inner ear. And it was seen that these people who were on aspirin were more predisposed to get problems as far as endolymphatic hydrops was concerned. And last but not the least, the hormonal imbalance. We will all realize that the estrogen level, I remember when I was a young boy, I was told that it is the menopausal stress which led to diseases like endolymphatic hydrops. And we used to see the ladies in their late 50s during the menopausal time that these things would happen. But now it is everywhere. And this is now not known that how does the estrogen increases. Now, high estrogen levels may lead to blood viscosity increasing, and this may lead to the sluggishness of the blood flow in the stria vascularis. That means the absorption of endolymph in the stria vascularis, because of the sluggish movement of the blood inside the stria vascularis, would lead to the hydrops formation. So this is the transverse absorption of the endolymph. That means it is formed in the stria vascularis, but then absorbed also, and that's the transverse. The longitudinal flow of endolymphatic hydrops is when it is formed in the stria vascularis and goes and gets absorbed into the endolymphatic duct system. And the low estrogen may lead to weakening of the otoconia, thus giving rise to symptoms like BPPV. So that means hormones had a great role to play. And what was happening to these hormones was that stress uses up most of the progesterone. Stress uses up most of the progesterone to manufacturing the stress hormone cortisol. So that means the levels of progesterone goes down in the body, and there is a comparative increase in the estrogen, which then causes the problem. And the similar thing we were seeing in menopause also, where the progesterone was decreasing and there was a relative increase in the estrogen levels. So hormones again were one thing which were directly being affected by the stress associated with the viral disease, coronavirus disease, what we had. And this was also to be looked into. We now do the estrogen progesterone levels and then treat the patient accordingly. If they're young and losing a lot of progesterone, that means comparatively the estrogens are going high and they're not getting better with the treatment. We also do the progesterone level, hormonal levels, and then substitute the hormones which are not there accordingly. Now, I'll come to the disease per se. This was what happened, whether it was the virus or the stress associated. But what happens in many years, I'll just give you a little idea so that you understand, you can diagnose it at the right time and treat it at the right time. At least the basic treatment can be done at the right time. Now, the three major things of Meniere's disease is episodic vertigo, fluctuating hearing loss, and roaring tinnitus. But it is the blocked ear, the initial symptoms, which are the most important, and we'll have to pick up a patient. Most of the blocked ear are treated in the form of station catarrh. No, it is not like that. If you see the tympanic membrane absolutely normal, if you find that the impedance is normal, it is not a case of station catarrh, and your mind should go into that probably this patient has some other disease. Now, again, causes are genetic, vascular, viral, allergy and autoimmune, environmental, increased salt intake and increased water intake, secondary endolymphatic hydrops. We in the Asian part have a lot of middle-ear diseases during the childhood because of wrong feeding habits by the mother into the infant. And right from the beginning, we'll have a sclerotic mastoid, unlike children in the Western countries where there is a lot of cellular mastoid. The whole thing is open. So when the endolymphatic duct passes through the Trotman's triangle through the Trotman's triangle in the mastoid, and if the mastoid is contracted, there is always a chance that a little inflammatory debris which will get into this endolymphatic duct would block the endolymphatic system. So that means we Asians are more prone to this kind of a disease than the Westerns, where there is a big skull, there is a big aerated mastoid, and definitely these things are not there. Now, in the etiopathogenesis, I've already told you it is a radial flow. That means the formation by stria vascularis and absorption by the stria vascularis, or the longitudinal flow in which it is formed in the stria vascularis and then gets absorbed into the endolymphatic duct and the sac system. Again, the predisposing factors as far as the mastoid bone are concerned, I've told you that the debris would get more entangled, more into the endolymphatic duct, which has been narrowed by the mastoid hypocellularity, the hypodeveloped Trotman's triangles. Even when there is an anteriorly placed lateral sinus or a sigmoid sinus, this can happen. There is a little natural kinking or narrowing of the endolymphatic duct, and this one gets further blocked by the debris caused by the viral disease, leads to formation of endolymphatic hydrops. Now, the staging of endolymphatic hydrops or Meniere's are, the stage 0 is the prodromic stage, but unfortunately, it is here that we have to diagnose Meniere's. It is here that we have to pick up patients suffering, and they'll come with very vague fullness in the head. They are not able to explain what it is happening. You find everything and it is normal, and then your mind should go towards this disease because very young children are now getting that. The stage 1 is the fluctuating stage, when there is fluctuating hearing loss, roaring tinnitus, etc. And then comes a disabling stage. That means the active stage has died down, the tsunami has gone, and now the destruction is visible. That means the hearing loss, whatever, is become prominent. Every time when there is an attack, the hearing loss would further go down and the disability would further go down. And finally is the stabilized stage. Now it is all stable. There is nothing going wrong. There is no vertigo. It might come back again after 10 years or 4 years or a few months. And this latent period keeps decreasing. And that is what Meniere's is all about. It will start with a difference of 10 years, then 5 years, then 2 years, and then, continuously you have Meniere's, and then it becomes a resistant case and it doesn't get treated. And the stage 3 is a contralateral ear stage. As I told you, vague symptoms, you are not able to make out. And if you are a smart clinician, you will pick up these conditions very early. Atypical Meniere's. It may not be Meniere's disease all the time that you have these 4 classical symptoms, and you will be able to diagnose it. It may only come as cochlear hydrops or vestibular hydrops, or as vague symptoms and atypical symptoms. So you have to be very careful in the beginning. And the unfortunate part is that the most damaging is in the first year of the disease. In the first year, when you could have cleaned off the debris in the endolymphatic duct, cleaned off the system in the endolymphatic fluid system, it would become a reversible thing. But now, if you are not able to diagnose it in the first year, the endolymphatic duct has finally got occluded completely, that is the time when we diagnose and it is got very late. The other symptoms which you should always keep in mind is deep-seated ear pain, burning sensation in the ear. They say कि लगता है जैसे अंदर गर्म सा कुछ है. I feel like something is very hot inside the ear. Tullio phenomena. Whenever there is a loud sound, you get dizzy. Tullio phenomena. Hyperacusis. You are getting irritated by the sound. Though you are hearing less, but the sound disturbs you more. So whenever some patient comes and say, by this ear, I have to close my ear because sound disturbs me in this ear, not in this ear. Please wake up and see that probably this is hyperacusis, which is one of the cardinal symptoms of endolymphatic hydrops. Irritation to the sound. They may come and say, I'm irritated to sound. Tinnitus, hearing loss, and vertigo are the last things. Once these happen, that means the destruction inside has already started, and now it is getting a little less irreversible. Little less reversible. It is now becoming an irreversible problem. As far as diagnosis is concerned, just to tell you, you may go to a doctor or you may have these kind of things in your clinic, that the audiometry, mostly it is history. You have to pick up these conditions very early. But when you get an audiometry done, sometimes you get a flat curve. 60% of the time you get a flat curve. So you have to see what is the age of the patient, and then you see, no, this can't be presbyacusis. This is not old age hearing loss. You will have to keep that in mind, that something is going wrong. Earlier we used to say, no, maybe something happened. Nothing can be done. Go and take a hearing aid. When you put a hearing aid, the patient say, I can't bear the sound because there is hyperacusis. Please understand there is something going wrong inside, gravely wrong inside. Now, there could be a low frequency hearing loss, which is the rising curve, 17%. Falling means high frequency. You will probably think it is because of noise trauma, high frequency hearing loss, but it is not like that. It could be part of the endolymphatic hydrops, and it could be within normal limits to profound. So please understand, a patient may come to you saying that suddenly everything went, and this is called a burnt out disease, a blowout disease. What happens is that the endolymphatic hydrops increases in such a fashion that the whole thing, the endolymph breaks up in the paralymphatic system. There is a mixing up of the paralymph and the endolymph because of the breaking of the resoners and the basilar membranes, primarily the resoners membrane, which opens into the scala vestibuli, and there is zero hearing. Everything goes away. Earlier, we used to say probably it is a viral infection or a vascular occlusion of the inner ear, but no, we have to keep this in mind also, so that we can now save the other ear. That means we know that Meniere's is a bilateral disease, and if one ear is gone completely like that, and if you treat this disease condition early, properly, you can even reverse the hearing loss. CC is a very good short increment sensitivity index. ECOG and VAMP, these are the electrophysiological tests what we do in our clinic, and these are sure shot. If ECOG is positive or VAMP is positive, that means it is a case of endolymphatic hydrops, and we have to treat it accordingly. But more important, please understand, is that we'll have to do a complete vestibular assessment. Even if the disease is written on the face of the patient, you still have to do a complete vestibular assessment, because there could be associated problems, benign paroxysmal positional vertigo, vestibular migraine, and other things. So you'll have to find out what these are and treat it accordingly. We have a very good vestibular lab in our clinic, which can really pinpoint the disease and treat the patient properly. This is important, not only for the purpose of ENT, for neurology and others also, for physicians also, because these patients come to all of us and we have to diagnose it. When I was running the vestibular clinic for 20 years in my hospital before I retired, we would say 80% of the diagnosis done by history. And that was the reason that only 20% of the patients were treated properly. And now we treat 80 to 85% of the patients guaranteed, because we are able to diagnose that thing properly by these latest machines, whether it is a rotating chair, whether it is a VNG, calorics, whatever we have, and we have a rehabilitation center, vestibular rehabilitation area in our clinic where if one of the ear is gone dead and there is inequality of stimulus coming from both sides of the ears, then we have rehabilitation where we adjust the brain according to this deficit, and they are able to, have a good balance later on. Now, just a word about paroxysmal. I was telling you that paroxysmal positional vertigo, either the otoliths could be in the canal when we call it canal lithiasis. It could be in the cupula attached to the ampulla. We call it cupulolithiasis. Now, these VNGs and all these can pinpoint whether it is canal lithiasis or cupulolithiasis, whether it is the posterior canal, the lateral canal, or the anterior canal, whether it is the right side or the left side. And this permutation combination makes 15 different kinds of benign paroxysmal positional vertigo, or it could be a multi-canal BPPV. So please understand, Eplase is not the answer for everything. We have 15 different kinds of repositioning exercises, and we'll have to do that specific exercise if we want to treat the condition completely. Otherwise, if you're doing Eplase again and again, the otolith might go, instead of going into the utricle, they might go into the other canal and cause even worsening of the situation and havoc. So please, you have to get these Dix-Hallpike tests done to understand where the otoliths are and which exercise they will be repositioned into the utricle so that they become redundant and ineffective. Now, we do other tests, very important. Thyroid function is one. Vitamin B2, 12 and D3, we have to do this also because deficiencies of this can also lead to that. P-ANCA and C-ANCA are for autoimmune. Skin prick allergic test, very, very important. You'll ask me, why skin prick test you're doing for many years? It could be underlying allergies to certain things. And if the blood allergy test is not so effective as the skin prick allergic test, and we have started doing for more than 110 allergens, we found out the allergen, give them immunotherapy in the form of oral drops, the meanies gets better. So that is why, because the predisposing factor was the allergy to certain things which they were not able to understand. And then hormonal assay, CT and NMRI. Important because there could be a small little tumor inside the internal aortic canal, which may be pressing onto the drainage of the endolymphatic duct system via the stria vascularis. And that pressure in the internal canal, we are thinking it is endolymphatic hydrops, but it is not a primary endolymphatic hydrops. It is a secondary endolymphatic hydrops. And then the primary thing, that means the lesion in the internal aortic canal has to be treated rather than the endolymphatic hydrops. Now, just a word about the management. I would start from below. Earlier, we were stressing on surgical. Now, I don't do a single surgery for endolymphatic hydrops. Can you believe it? Because we used to do it, and third day, the opening would get closed, the drainage tube which we would put would get closed, and we had to open it again. Total, only 10 to 15% result in sac decompressions would come up. Mennett's device, that is the vibrator, no, it doesn't have much effect, even in the smaller cases. Psychotherapy, very important. We have to make the patient understand that the disease is still early and treatable, and we treat the patient by drugs and intratympanic steroids. Now, I'll tell you, beta-histine, paracetam, diuretics, and steroids all have to be given together. In my practice, I've realized that if you give only beta-histine, 2 to 3% cases show no response. If you give only steroids, 2/3 of the cases will not give response. If you give all four together, the results are very good, because paracetam increases the blood circulation in the stria vascularis. It reduces the erythrocyte adhesions, thus lead to better drainage of the endolymph into the stria vascularis, and diuretics lead to less formation of the endolymph. So all these four things are important. And the most important is that most of the time we Asians are now suffering from diabetes. We cannot give oral steroids, which have to be given in these conditions, or IV steroids, and we give intratympanic steroids because they get absorbed from the round window into the inner ear directly and go and act right at the stria vascularis or clear up the blockage of the endolymphatic duct system, and thus acting directly. So it increases vascularity, steroids, reduces the inflammatory process in the labyrinth, which is very, very important because the debris is going and getting stuck into the endolymphatic duct, restores normal functionality of the stria vascularis, regulates inner ear de novo protein synthesis. So the sluggishness because of high protein in the endolymph doesn't lead to blockage of the stria vascularis, and improves excretion via the longitudinal flow. It is like if you have a sink where you are washing your utensils blocked, then first thing is to close the tap so that less water comes in, and then we try to flush off the sink with our hands so that the water is pushed off. But lastly, it is important to pump the the drainage pipe with something so that whatever is stuck there is cleared off. So all the things are very important. Endolymphatic hydrops will not be treated if you're just giving Vertin, if you're just giving Diamox, if you're just giving paracetam, or if you're just giving steroids. It has to be a combination of these four things so as to, if you want to treat endolymphatic hydrops proper. And I can tell you, many people out there are suffering post-COVID because of this disease. Many people, young to old, everybody. And this is how we give the endolymphatic system. This is a serious thing to do. So you'll have to send the patient to an ENT surgeon who can put it. You can see the thing is gone. Now the head is tilted and the patient is allowed to lie there for about 20 minutes so that it goes into the inner ear through the round window, and the results are extremely good, extremely good. Intratympanic we are using for steroids for acute tinnitus, sudden sensorineural hearing loss, Meniere's disease, and endolymphatic hydrops. But the chronic tinnitus cannot be treated by this. Please understand, people are coming to us with chronic tinnitus also. And if it is not treated, the acute tinnitus post-COVID is not being treated properly, it becomes chronic. It is more of a phantom noise now, which has to be treated by masking. And there is a definite way by which we mask, very good way by which we mask. And that it has now become a phantom noise. It is not there in the ear. The primary disease in the ear probably has got healed, but you are not forgetting it. You know, it is like, I always give an example that if a father has 4 sons and the father dies, 3 sons start their day-to-day work. From the next day, one gets into depression. We have to distract that 4th son so that it becomes, he goes out of the depression and becomes normal. So chronic tinnitus would be treated only by masking, and we have to match and mask. That is what it is all about. I have a very good center where all this treatment is being done. We have an auditorium of 50 people within the center. There is no surgery. It is only a diagnostic center we have. And we are doing skin prick allergic test, all VAM, CHAMP, ECOG-G, BERA, ASSR, everything is done here. This is a skin prick allergic test, the VNG, everything is done under one roof. And post-COVID, I've realized how important it is to have more and more of these centers everywhere, so as to we can diagnose these people properly early and treat them properly. Thank you very much.
Thank you, Dr. Hans. This was an excellent presentation, and we will now open the floor for question answers. Can I have the doctors asking the questions back? Dr. Hans, can we stop sharing the class slide?
Okay.
Can I?
Yeah.
Yeah, hi. So the floor is open for the question answers.
This is a very special topic, actually. So Dr. Sajjad, he's the right person to talk about, I think. Can I have just one question, actually? When you are telling the mental stress is causing the increment of the antidiuretic hormones, so it will have the systemic effect also. Can you just enlighten us?
Definitely. I have seen, and I used to purposely ask the patient, do you have pedal edema? See, the problem is that most of us Asians are suffering from some cardiac problems always, whether it is diabetic cardiopathies or otherwise. But you never know. You never know that these antidiuretics are there. They are not able to, and the ear and the kidney are both embryologically they derived from the same germinal epithelium. So whatever if this can happen in the ear, definitely it can happen in the kidney also, and people may be suffering from these kind of situations, a pedal edema, puffiness of the eye. I'm sure they would be, but as physicians, they would be able to tell better rather than me.
Thank you so much. Thank you. It's really very interesting and very useful topic you today.
Thank you, Dr.
Thank you
Jamal.
so much.
Thank you very much. So kind of you.
Yes, Dr. Ashok Gupta.
Thank you, Dr. Hans. Wonderful presentation.
Thank you, sir. Thank you.
I just was wondering about the role of intratemporal, intramembranous
Tympanic, sir. Yes, sir. Very important.
I think is a wonderful thing, because I personally experienced with one of my very close relatives. He had a hearing loss post-COVID, and he was suggested all sort of procedures. Incidentally, one of my colleagues suggested, though, we should not do all that oral steroid and systemic steroid, and he suggested transtympanic steroid, and there has been almost 99% recovery of the hearing. And
so you would believe that we understand that there is some vascular problem in the inner ear. That means the oral steroids, what we are giving in so high quantity, may not be reaching that area where we need the steroid, and it is affecting the body per se. Intratympanic steroids have proved to be really, really helpful as far as ear diseases are concerned, because we have that round window and the membrane is very thin, and actually the steroid can, actually the moment we give the intratympanic steroid, we can see the patient getting into a vertiginous attack because the steroids are getting into the inner ear, and very good results.
I think this something message you should convey to entire ENT community. Many of my professional colleagues were not agree to this, and even insurance company refused to accept this treatment.
No. This is a very good. I mean, for the last about 4 or 5 years now, we have 4 stations in my clinic, 4 microscopes and 4 stations. Yes. I tell you, they're all busy most of the time because patients are coming from all over. I mean, I'm getting patients from Bangladesh, Nepal, yes, all these areas, very far away.
So it's a wonderful method, and I think should be popularized, and it should be stressed upon by the insurance company to accept this as a method of treatment.
Absolutely, sir. Absolutely.
Dr. Elvin from Hong Kong.
Yes, thank you very much for the very enlightening lecture. Thank you, Dr.
Thank you, sir.
Yes, may I ask first, it is a synonym for the vestibular neuronitis, as also with the endolymphatic hydrops, and
no.
And are there any viruses implicated in the causation of any viral origin infection, or is it a post-infectious thing? And thirdly, then, when there is the history of viral infection beforehand, so would we think that that could be related? I mean, for the acute one, not for the chronic one, or anything like a acute on chronic presentation. And so when the patient also have, say, vomiting, is it common, or it is a part and parcel presentation of the Meniere's disease, or it is exceptional thing to have vomiting or nausea? Well, some patients even presented with nausea, vomiting and diarrhea, and then sometimes could mislead the clinician to think of some gastroenteritis as well. Or will the viral infection also cause gastroenteritis at the same time? Or it is, in fact, misleading symptom or sign in that way. So vomiting, is it a genuine or part and parcel of this?
See, any ear disease for that matter, we all know that the vagus nerve supplies the ear and it supplies the stomach and the heart. So anything which stimulates the inner ear can actually stimulate the vagus nerve and lead to kind of a nausea form feeling. But please understand, the virus may lead to a gastroenteritis thing also. So virus and loose motions can be, the vomiting and loose motions can also be because of that. But when it comes to the ear, there should be some oral symptoms also. Oral, when we say AURAL, oral system symptoms like fullness in the ear, positional nystagmus or positional vertigo, maybe some hearing loss, as in Meniere's benign paroxysmal positional vertigo will not have cochlear part, but it will have only vestibular part. Sometimes it becomes even more difficult to find out whether it is vestibular hydrops, or it is vestibular, neuronitis, vestibular neuronitis. In that, the nerve is affected. And when I showed you the first slide, there are viruses which affect only the dendrites, whether those dendrites are coming out from the cochlear part or from the vestibular part, because the vestibular part of the nerve is different and the cochlear part of the nerve is different of the eighth nerve, but they could be arising from those dendrites. So if the virus has affected only the vestibular neurons, it can present as vestibular neuronitis, but because the vagus nerve also gets stimulated and there is vomiting, it can be there. But please understand, to say whether it is gastroenteritis, viral, or inner ear viral disorder, we will have to see other things. The symptoms pertaining to the ear could be present, like positional vertigo, or blockade in the ear, or tinnitus, or hearing loss.
Yeah, thank you. In fact, I had joined the lecture late, so I had missed the first few slides.
Yeah, that slide I showed. See, all these viruses, the upper respiratory viruses, whether it be measles, mumps, rubella, cytomegalovirus, HIV, herpes, all these have a predilection for the inner ear. And in my first presentation, I said that these viruses affect different parts of the inner ear. Some affect the stria vascularis, some affect the dendrites, some affect the other parts, and at the moment, we don't know what corona is doing, where exactly in the inner ear corona is affecting. Maybe later on when we do research, we'll be able to pinpoint where it affected. But yes, it can affect any part of the inner ear and thus lead to different diseases, which I enumerated.
Yeah, thank you very much. I would be grateful if you can allow us to have your slides again in the PowerPoint form, if you can allow Saurabh to send us.
We can request Saurabh Agarwal to put it on the net, the whole lecture, so that anybody, anytime can, download it.
Yeah, thank you very much. Thank you.
So this is live, and we will send you the link and the presentation after this thing. Dr. Salma from Pakistan.
Assalamu alaikum.
Walaikum salam.
जी कैसर डॉक्टर कैसर take over.
Hello. Yeah, Dr. Sajjad, you're saying something?
Yes. I just missed because of the internet problem. Did you ask something?
No, you were unmuted, so we thought you were asking a question. Okay.
No, it was very fantastic. I just want to say that Dr. Hans is presenting a fantastic and providing the fantastic information to us. My observation is, Dr. Hans, is that we have in Pakistan also the cases of vertigo and tinnitus, but not in the more in the post-COVID patient. We have lots of patients with the cervical spasm, which is very common in the young generation. As you have said, the young generation, the teenagers even coming with the complaint of the vertigo and tinnitus, and which is being relieved after giving treatment for 2 to 3 weeks, which is very good. But I have seen post-COVID of this symptom is a very less number of patients having post-COVID symptom of vertigo and tinnitus. But what I am observing, and I'm making a data also, that the young generation is having more cases of vertigo and tinnitus, and sometimes when the symptom is aggravated, it causes vomiting also. So this is my observation, and thank you very much, sir.
Dr. Sajat, I must humbly tell you here is that cervical spondylosis is no more a cause of vestibular vertigo. Please understand,
No,
it can
just
lead to
asking the spasm, cervical muscle spasm.
I'll explain it to you.
Okay.
Cervical spondylosis can lead to vertebro-basilarity insufficiency and pain, not vertigo. The spasm is secondary to the vertigo. You know what nature does is it forms a kind of a muscular collar so that the head remains stable. And it is the muscular collar which, because of the strap muscles in the neck remaining tight most of the time to keep the head straight, is the cause of pain in the cervical part. And the straightening of the spine, what we see in the X-ray, is primarily because of a sequelae of the straightening of the, is because of the spasm of the muscles. So now, as far as vertigo is concerned, we have stopped saying cervical spondylosis being part of vertigo. It is only vertebro-basilarity insufficiency because of the blockage of the vertebral artery system. That is the cause which may lead to vertigo. And that vertigo has a very characteristic feature that you have a blurring of vision for a few seconds and then everything becomes all right. Or it could prolong also for a little. So when we talk of vertigo, which is vestibular, we don't have blurring of vision. There is no vascular part involved in that. So no blurring of vision, no sinking sensation. All these are part of the vascular condition called the vertebro-basilarity insufficiency.
Okay, thank you very much. I have another question to you regarding the tinnitus.
Yes,
I missed your few parts of your presentation. Do you have the proper treatment of tinnitus of the older patient as well as in the younger patient?
Achha, no, I told there, sir, Dr. Sajat, I told that acute tinnitus, which is because of the distension of the endolymphatic system and stretching of the neural element inside, can be very well treated by diuretics, by intratympanic decadron. But once it becomes chronic, now it is more of a phantom noise in the head rather than the disease in the ear, and that is treated by tinnitus matching and masking. And that we have a very good system here in our clinic where we can match from 80 decibel to 16,000, 80 hertz to 16,000 hertz. Normally, most of the audiometer match between 500 to 4K only. Here we are doing between 80 to 18,000, so that the matching is given accordingly. The white noise which we used to give for matching earlier is now an obsolete thing. We match according to the sound which is coming. We have 500 sound in this app we give on your telephone, and you can actually match it according to the tinnitus which is coming. And the prognosis is very, very good.
Very good. Thank you very much.
Can you go ahead with your question?
Dr. Pillai here.
Dr. Pillai,
Excuse me.
yeah, can we, Dr. Pillai, can we have Dr. Salma and then after that?
Okay.
Yeah. Go ahead, Dr. Salma.
May I ask a question?
Yeah, sure.
Yeah, please.
It was a very informative talk. Thank you, Dr. Hans.
Thank you.
Actually,
Thank you.
I'm a post-corona sufferer, and I developed after 6 weeks of my having initial symptoms of COVID, I developed the tinnitus, and now it's been a year. And I'm so grateful for this talk. First of all, can you please tell me, Dr. Hans, where your facility is located? Because I'd like to come and get treated.
Where are you? Where are you placed?
Pakistan, Ahmedabad.
Oh, this is in Delhi. But I can tell you, we can actually do it virtually also. tinnitus treatment is now
Oh,
virtual
great.
also. Yeah.
Oh,
So
great.
after that, I'll give you my telephone number. And once in my clinic, what we do is we try to match your tinnitus and then send you an app which which we put it in your Android phone, and you can hear the sounds, and that the masking effect occurs with that. So we can do it virtually also. If it is not
But
possible
that
for you to
masking
come
would
to clinic.
last till this procedure lasts, or it will last
No, you
throughout
have
the
the
day?
app in your phone. You can use it as the tinnitus till the tinnitus is there. So if it comes back, you can still use the app or stop using it, the app.
Well, the tinnitus is 24/7. What do I do with that?
No, but see, I gave an example, and I think I'll give you an example again. Some people have more of serotonin release. Now, the serotonin doesn't let the tinnitus go away. You will understand the serotonin is a hormone which gets secreted in the in between the neural endings. So this doesn't lead to the the sound keeps coming. So it is the treatment of this is to divert the brain from this sound. And this is what we do by this app, but we have to match your tinnitus first and then mask it accordingly, which can be done. Once it becomes a chronic tinnitus, then intratympanic decadron doesn't help.
Okay, so like I'm a chronic case now.
I'll connect you with him.
Saurabh will give you my telephone number, and we have
Okay.
I give virtual treatment also. Nowadays, COVID has taught us this also, and the patients are getting all right.
Thank you.
Okay.
Stay blessed.
Dr. Pillai?
Thank you very much.
Yeah, thank you. Dr. Hans' presentation was very good, very informative. Thank you for that.
Thank you very much.
Yeah. One thing which I would like to tell you, this estrogen levels, my understanding is that the estrogen levels in females definitely gives them protection from stroke and the slowing of circulation. Only menopausal women, when the estrogen level comes down, they become more predisposed for stroke. So your presentation, you mentioned that slowing of circulation is caused by increase in estrogen level. So some clarification on that. Second is, of course, the intratympanic steroid injection. The indications definitely has to be sort of laid out so that there's a lot of process for tinnitus and vertigo. And I hope it is only for benign paroxysmal positional vertigo that we are trying this intratympanic steroid injection. And the third thing is that post-COVID, it may not be vertigo, but dizziness and imbalance can be caused by autonomic disturbances, which is very common in post-COVID patients. So that again has to be borne in mind when we talk about tinnitus and vertigo, because this is much more common. That is what I feel. Thank you.
Yeah, very good. Thank you, Dr. Pillai. And your first question was about high estrogen levels. Please understand, when I say high estrogen, it is comparative increase. See, we have both progesterone and estrogen. When the levels of progesterone goes down in a young boy or a young person, the estrogen level comparatively increases, and then it becomes an adverse condition. See, we have this balancing system in our body. The progesterone also has to be at a level to do its functioning. But when stress takes away the progesterone because of a conversion into cortisol and other things, then the comparative, they say even if you are good, but too good is also too bad. So estrogen then becomes a bad thing if the progesterone levels are following. So we have to have a balance of progesterone and estrogen. Only then estrogen has its positive effects. We all know women are more stronger than men, and it is because of the estrogen, but the progesterone also has to be there. When the progesterone falls, now what happens during menopause? There is a natural decrease in progesterone, and that's why a comparative increase in estrogen, and that's why they have problems of menopausal stress in that age group, and vertigo is one of them. And it is the endolymphatic hydrops which occurs because of high estrogen levels because of the levels of progesterone going down. Please understand, when I say more estrogen doesn't mean estrogen going, you are giving estrogen for some reason, like fertility purposes, etc. Then also women would suffer from this disease. So it is the comparative disbalance between the two which is causing the problem.
Okay, thank you.
The second was, second question, can you just tell me again?
Intratympanic.
Intratympanic decadron is a very good thing, but please understand there is always a problem with any kind of treatment we are giving as humans. Now suppose if there is a double layer on the round window, there is a round window membrane and then there is a thick mucosa. The steroid may not reach in that period of time we are putting the patient for 20 minutes, but definitely some would go. It will it will go through the mucosa and then into the round window and then into the inner ear, but it will take some time. So these are the patients who will have to be given more intratympanic injections rather than a few who get better with just 2 or 3 only. So that is what intratympanic is. And intratympanic decadron, the side effects of decadron are taken away. The oral side effects, high acidity, water retention, diabetes, all these are taken care of when you're giving intratympanic. The results are very good and the effects are very good. Please also understand that most of the time we are saying there is vascular occlusion, maybe one of the causes of the disease. And when we are giving steroids, the steroids are not reaching the stria vascularis. So we are just giving steroids and steroids are causing their side effects and not the desired effect we want. That is what it is.
Thank you.
Thank you. Any other questions on the floor? Dr. Nisha, you have a question. You have raised your hands.
Good morning, colleagues. I'm Dr. Nisha Jacob. I'm a public health physician at the University of Cape Town in South Africa. I attended this webinar because I myself am a patient having recently suffered sudden sensorineural hearing loss and tinnitus. But as a public health physician, I'm also a keen vaccine advocate and I've been strongly promoting vaccine use. However, there's a growing number of anecdotal case reports of vaccine-related hearing loss and tinnitus. And personally, I have not had any evidence of COVID in the past 2 years of the pandemic. So I've never had COVID. And I just wondered your thoughts, Dr. Hans, was a really fantastic presentation. I just wondered your thoughts on the recent reports of hearing loss and tinnitus related to any of the vaccines in the absence of a history of COVID.
Dr. Nisha, I will not be able to comment more because these are people on the field and the ICMR people in my country who are finding these things, but definitely people have come to us who had this injection, but we were not able to make out whether it was the injection causing the problem or the COVID causing the problem. We did not go into that, but that's a very good study. And I think we can go into that also, maybe ring up our patients back and find out if the problems were because of after getting injections. But we would realize that once we give the injection, we are trying to create the same scenario of COVID situation, if not in that way, but definitely in a subclinical way. And it can, this virus or whatever toxins you put inside to get the immunity can also go and affect the inner ear. It can definitely happen. And I think more needs to be studied in this.
Thank you very much.
Yeah.
Thank you. Dr. Charu?
Yeah, I'm a senior microbiologist. I just want to make a comment on Dr. Sajad, who narrated that his younger patients are getting vertigo and tinnitus and no COVID. But I really wonder because in young generation, it is mostly asymptomatic and we may not have tested them. If we do later, even the antibody level study, then majority of them you will find that they are antibody positive and we never knew that they are suffered from COVID. So this may be the reason. Okay. Because in Delhi we have done study and without even symptoms, patients are antibody positive. It means they were having COVID, but they didn't show any symptoms. Just a remark.
Thank you, Doctor. We have some questions on the Facebook where one of the gentlemen has asked, is the medication a long-term treatment advisable for tinnitus and vertigo?
No, I don't think so. We have to stop the medicine as early as possible. We are giving piracetam for a longer period of time because it increases the vascularity of the inner ear, which may have got hampered. Very difficult to say for how long, because what we are doing is we are going by the symptoms of the patient and what the patients are telling us. If after about a few weeks, 6 weeks or 8 weeks, they say we are absolutely fine, we tend to taper it and stop it. But if they say, no, we still have, many of my patients, had the symptoms recurring after the medicines were stopped, particularly the piracetam, because this leads to, increase in vascularity of the inner ear. Then we asked them to start again and they were better again. So for how long we are studying, we are giving it for very long. Why they are acting even after 6 months is to be seen. I mean, we have to still study that why some need for so long and some become all right within 1 or 2 weeks only.
And so what about Vertin?
No, there is no need for Vertin to be given for so long. Any vestibular sedative or stimulant. Beta histine is a vestibular stimulant, whereas cinnarizine, stugeron are vestibular sedatives. These have to be given for a very limited time only, and after that stopped. I'll give you an example. If we just keep giving this and don't treat the etiopathogenesis, we are not doing the right thing. It is like if somebody is depressed, every evening you ask him to take alcohol. That is not the treatment for his depression. His depression has to be seen in a different way, treated in a different way properly. So here also, beta histines and cinnarizines are not to be given for a long period of time. And that's the problem. I have seen patients coming from different doctors getting beta histine, cinnarizine, stemetil, all the things. So it is like, if you're not getting better with alcohol, please take drugs also. Not, what we are leading to central and peripheral vestibulopathies. That means the vestibular system is stopped acting. And then this dizziness would remain forever. So we have to stop them as early as possible and put these patients for vestibular rehabilitation exercises so that the brain now acclimatizes to the wrong stimulus coming from the ears and the eyes and the other areas of the body. So vestibular rehabilitation is the answer rather than giving them beta histine, cinnarizine, stemetil for a very long period of time.
Thank you, Dr. Hans. Dr. Ashok?
So,
yeah, Dr. Jamal?
Dr. Saurabh, actually, just in conjunction with the question raised by Dr. Mishra from South Africa, I must also ask or request Dr. Sims that actually, some days back, there was a public hearing on vaccination, and there was actually complaint that it was actually raised by the Israeli authorities and others that the heart disease has increased actually due to vaccination. So this is also to be looked after. Actually, what we are going towards and what is happening actually post-vaccination. Isn't it? Don't you agree with that?
Yeah, definitely. The side effects would come gradually.
Thank you.
Dr. Ashok?
Yeah, thank you, Dr. Hans. Just a very hypothetical question. Is the incidence of chronic hearing loss or tinnitus has increased following COVID, or we have become more aware of this, or they were being reported even earlier also, and the transtympanic treatment was effective in earlier days?
Sir, please understand, during COVID, people have stopped coming to the clinics. And if they're coming, that means they're suffering. If I see 25 patients nowadays, I used to see more than that pre-COVID, and there were nasal blockages, sneezing, very small things, and they would come to the clinic and show me. Today, whosoever patient comes if they are really suffering. And if out of the 25, 15 or 16 are the ones with tinnitus, hearing loss, and vertigo, and very few, I mean, believe you me, I have not done a tonsil and a septoplasty for a long time now, because they don't bother. They say, oh, con. Going out and showing a doctor and getting hospitalized is more dangerous than, I can suffer with this.
Yes.
So on the whole, our patients have decreased, but these patients have increased. So that means if you combine all the patients, these patients have increased manyfold. So the only thing which I see is probably COVID. And when I studied about it, COVID and virus are the cause. I strongly feel, because all these upper respiratory viruses have a predilection, we know, for the inner ear, whether it is measles, mumps, rubella, whatever. So why not coronavirus? I mean, I'm sure we will come authentically on this later on, but definitely stress we know is causing. And we now know that the post-COVID stress syndromes will be more dangerous than the COVID itself, whether it is psychiatric problems or vertigo problems or tinnitus problem, cardiac problems. Many people are getting cardiac problems. So whether it is because of the stress causing, leading to estrogen hormonal imbalance, we'll have to really study hard.
Have you seen any complete hearing loss?
Many, unilateral, bilateral, many. My implants have gone up. I don't know whether they could have lasted another few years without the implant or keep doing good on hearing aids, but my implant numbers have gone up. So that means something went wrong somewhere.
It's a very interesting incident which I want to share. One of my very close relative and an advocate by profession suddenly realized that when he was holding a phone on one side, he was not able to listen.
Yeah, there was sudden sensorineural hearing loss.
That is how he got diagnosed. Other side, he was listening. So when
Absolutely.
he consulted an ENT surgeon, he said, what is the big problem? You learn to live with here only on one side. Why you bother about the... And because he was not ready to admit the patient in a hospital, nor he was admitted. And COVID has really changed the life of a surgeon.
Yes.
A plastic surgeon, like we said, septorrhinoplasty for last 2 years, I have not done a single septorrhinoplasty.
Single case. Nobody's bothered about cosmetics now. Yeah, they're bothered about not going to the hospital.
Yeah, breast augmentation, lipectomy, which I used to be bread and butter every day, 2 or 3 cases.
Yeah.
So there's a drastic change in the life of a surgeon.
Lifestyle, yeah. So if they're coming to the clinic and getting these tests done, see, this is a 1 hour, VNG is a 1 hour test, and they're getting it done. That means they're suffering,
So is there a shift of medical issues following COVID?
Definitely. As far as I see, it is now I don't mind calling myself an inner ear specialist, because this part of the diseases have gone up rampantly. Others have gone down.
So we are changing from a surgeon to physician now.
No, for me, my bread is cochlear implant, so I'm getting a lot of patients. I mean, I shouldn't be saying that, but definitely hearing loss is what I do. So they are going up very, very much.
Thank you, Doctor.
Thank you.
Thank you,
Dr. Pillai here. One observation: there was some discussion on adverse effect of vaccine. One thing, as a medical man, all of us have to promote vaccination. There may be some side effects, but as a public health responsibility, we have to promote vaccination. Second thing is, of course, some of the side effects with vaccination have been the technique of giving the vaccine. If you pinch the skin and give it, many a time, it is in the subcutaneous vascular level, and intravascular, it becomes an intravascular injection, and that can cause more side effects. If you are not pinching and directly giving, and if it goes to the muscle, then of course side effects are less. So the technique of giving the vaccine is very important, which again has to be popularized to reduce the side effects. Thank you.
But Dr. Pillai, why pinching the skin for this intramuscular injection?
No, you are supposed to give it intramuscularly, and it should not be in the vascular layer of the skin. When you pinch
no, I'm just talking about the intramuscular. When you are talking about the intramuscular, then no need to pinch up the skin. That is I'm telling.
No, this is supposed to be given intramuscularly.
Yeah,
because it won't enter the vasculature.
So I don't think we have time for a country update. So we'll continue with the question answers for another 5 minutes.
Saurabh,
Yes,
can I
Dr.
ask? Okay, Dr. Hash, can you have any data for the ENT doctor which is being expired due to COVID? Do you have any number of doctors expired in ENT surgeon expired due to COVID?
I think all this research would be done once the COVID is over, or maybe now there is another virus variant which has come over. So let us get out of this,
but
and we'll start.
But we have in Pakistan 10 ENT surgeons being died.
Yeah, we have a lot of
10,
them.
10
In
out
our
of
country, probably
surgeon-
400 of ENT surgeons have gone. I mean, that is what I've been told. I mean, very sad to hear.
Oh, wow, too high.
Very sad, yes.
Yeah.
But we have to be very careful. I think it message should be passed to all the ENT surgeons that the ENT surgeon, the eye surgeon, the dentist should have an extra precaution measures. Yes.
Yeah,
absolutely.
Yeah. Since we have Dr. Monica,
Actually.
Dr. Monica, do you have any information on the vaccination? The question which was being asked, and I know you're sharing some information also. Do you want to speak anything on the vaccination side of it from ENT point of view or any other?
I agree that when we're talking about these adverse events, that these events are very, very rare, very rare. So it always should be done in the context of the risk-benefit ratio. There have been tinnitus reports that I'm seeing, at least from a preliminary lit review, that there has been tinnitus that's been associated with other vaccines, again, on a case report basis. But as Dr. Hans has said, we need to do kind of a more formal review. There has to be more information that's provided. I see that Dr. Jacob had said that her antibodies were negative. And I always just caution when it comes to assessing antibody levels that it's not necessarily always the best, the most accurate, and it's dependent upon the lab. And I know in South Africa, they have amazing labs available to them, but the information coming from other countries are not so good, or other labs, not countries, but specifically labs, it may not be so good. When we look at antibody levels, we have to go, are we looking at spike protein specific antibodies, whereas are we looking at antibodies to the entire variant? So there's differences to assess natural infection versus vaccine-related immunity. In terms of other news related to vaccines, there's been a movement in the United States more recently to not recommend the vector platform-based Johnson & Johnson vaccine, which is the same platform as AstraZeneca, and to instead recommend the mRNA, Pfizer and Moderna. The other news that's been out more recently about the vaccines is related to its neutralizing capacity with the Omicron, which I think most of us are following pretty closely, and reviewing that booster doses do bring up the level of neutralizing antibodies in those who do get the booster against Omicron. And so there's been now a much stronger movement to promote immunizations, even in the setting of anticipated side effects, especially in face of the Omicron variant. We are seeing a doubling time now of 2 days in major cities like New York that's been reported. There are multiple segments that are reviewing the concern related to the Omicron spread. And we are experiencing a very, very distressing surge in terms of hospital bed utilization. Because even if the numbers of people who are infected are much higher, the number who have received the booster dose is very low. And so this vaccine, this virus has now taken a foothold where it is rapidly spreading, rapidly duplicating, and we don't have the level of vaccine community immunity. There was I think on December 8th, there was a Norwegian party. There was, I believe, 120 participants at the party. They were all tested negative going into the party and they were vaccinated. And I heard something like 70 or 80 people came out from that party infected, and they all had Omicron. So any discussion that we have related to the infection versus the risk of immunization, as Dr. Hans has alluded to, we've seen many more cases of tinnitus related to the infection, and the infections related to the vaccines or the tinnitus related to the vaccines are still on a case-by-case report basis. That could also reflect that we've just not reported it, or it's not been understood to be reported. I think that we're in constantly evolving information. I think the information continues to evolve on I feel like an hourly basis. So I hope that was at least a fair assessment of where we are at this point in time. Thank you.
Dr. Monica, Can you just tell me, the WHO Secretary General had just cautioned that although it said that Omicron is a mild infection, but the number of hospitalization will be increasing. He is suspecting, he's expecting that. Is it just proportional, or it is related with the comorbidities? Who will have the comorbidities and go for the hospitalization? What do you think about it?
Okay, so there's two things that are going on. Right now, the patients that are hospitalized are mostly those of Delta, right? So we're still in a Delta surge right now. So as Omicron spreads to many, many more people, even if, say, for example, if the hospitalization rate for Delta, and I'm making up these numbers, are 1 out of 100, and hospitalization rate for Omicron is 1 out of 500. However, if we infect many more people, then the denominator is so large, so will be the numerator, even if the numerator is much smaller. So we are losing this time race because we need to really make sure that we have vaccinations available, booster doses available. We have Regeneron monoclonal antibodies available. There's another product that's specific that works for Omicron. It starts with the letter S. I can't recall its name right now. There's not enough doses of that. There's a new Pfizer pill. They barely have hundreds of thousands of pills available if it becomes completely approved. So I do believe that we are right now at the edge of a cliff, and especially with the holiday season and people who have made travel plans and are continuing to making travel plans, that it'll be interesting to see whether or not we are actually right up at that cliff, or if there's a little bit of room where we can say that, okay, we can see it, but we're not going to jump over. We don't know where we are right now, but there has been a lot of information, at least in these past few days, about how rapidly this Omicron variant is spreading, how they're finding it in the sewage waters, and so that the numbers will increase. That doesn't necessarily mean that it's hospitalizations in response to your question, but we are currently in a Delta surge of hospitalized patients. Our hospitals are near capacity. We are already in a Delta wave. We're in vacation time, and we have Omicron coming. So I feel really bad, Dr. Jacob, regarding your situation. I see your message. You said that your N antibodies were negative 3 weeks post, and you had sudden hearing loss, and your S spike antibodies were positive, and this was assumed to be vaccine derived. You were given the Johnson & Johnson vaccine, which is the viral platform, and it's unsure for you whether or not you should be given a booster, given the risk to your right ear with both J&J and Pfizer. So there's two things that I would say to you. So my training is an allergist and immunologist, and I do a lot of first dose risk assessments. So option one is you do no further immunization. And if you do get sick, you seek monoclonal antibodies if that is available to you. So you test frequently. And the assumption is that I'm assuming you got your vaccine at least 6 months ago, that your protection level warrants boosting and that you could get monoclonal antibodies. The second thing that you could do is you can wait for another platform altogether, such as the protein-based Novavax, where the Serum Institute has given quite a bit of data. There was a lot of information related to the Novavax. And I would probably say that if you can wait, I would probably say then you could try a vaccine like Novavax. The third thing to do is to understand whether or not there are therapeutics available for your tinnitus. So you can even avail of Dr. Hans's specialty to see if you can clear the tinnitus first before you move forward with an unrelated follow-up immunization. But because Pfizer and Moderna are a separate platform than the vector vaccine that you got, it is possible that you could bear the benefit of the mRNA vaccine without the concern for the same side effect with the Johnson & Johnson. So do nothing, observe, do nothing with pursuit of monoclonal antibodies with frequent testing, early diagnosis and detection, or moving forward with a completely alternative platform like Novavax. So that's kind of like my approach to most of the patients who come to me with first dose issues. But I do feel, again, the bottom line is the risk of side effects and complications from infections far, far exceed those related to immunizations. Thank you.
Monica, this is Dr. Kaisar Sajjad. I just want to take an advantage of your presence. About the booster dose, the single booster dose is enough, or now you can say the second booster dose is necessary now? As you said, I think a couple of months before that, the single booster dose is enough. What is your opinion now?
Yeah, great question. Okay, so I got my original doses of Moderna in January and February of this year. My before Omicron came, I was thinking I would get my booster dose in January and it would protect me for potential anticipated travel in March, which is when my kids have their spring break. So as soon as Omicron became known, I actually got my booster 10 days ago. And I opted for Moderna instead of mixing and matching. In my opinion, and this is my opinion, I believe that we're probably going to need booster dose again in 3 months, and that a fourth dose will be considered based on where we are in the pandemic. I don't know. My original thought was that there was going to be just an original booster dose, and then we would get the recurring updated booster dose along with our seasonal influenza immunization in August, September of 2022. I do know that Pfizer, I knew that Moderna have looked at other doses. I don't have any of the data related to that. I haven't reviewed that information. I'm sorry, I'm not up to date on that. But I do know that they have been looking at that as well.
Well, thank you very much, Monica.
Yeah, you're welcome.
Well, thank you. I think we are at the end of the session. We have over exceeded the time and we have a next session coming up. Thank you, Dr. Hans, for being here.
Thank you very much.
It was a pleasure to accept. He had to prepone his surgery and he's flying to US today. So I think it was a very nice gap to just cover up and come over here and enlighten us for the ENT issues coming up with the long COVID. With this note, we will end the 89th session. We'll meet up again next week, same time, same day. With this note, I would like to thank all the associations and especially Dr. Monica coming from US for enlightening us for all this information. Thank you, everyone, and stay tuned for next session.
Thank you. Thank you.